Everyone, me, MANUKIL and Jason Verdida were assigned to prostate cancer. Prostate cancer is a cancer that occurs in the prostate, which is a small walnut-shaped gland in the man that produces and functions the seminal fluid that nourishes and transports sperm. Cancer of the prostate is the most common cancer in men other than non-melanoma skin cancer and is the second most common cause of cancer death in American men. African men are twice as more likely than any other racial or ethnic group to die of prostate cancer. So there are three main stages of prostate cancer. So first stage is the localized. Cancer is just in the prostate gland, while in the second stage, the locally advanced prostate cancer has already spread beyond the prostate capsule, but still connected to the prostate gland, while on the third stage, the advanced and metastatic prostate cancer stage, in it is already spread outside the prostate gland with no remaining link to the original cancer in the prostate gland, so it is already severe. So the epidemiology of prostate cancer is that according to the latest World Health Organization data, which was published in 2018, prostate cancer death in the Philippines reached 3,319 or 0.54% of the total deaths. The age-adjusted death rate is 14.97 per 100,000 of population, ranks Philippines as 104 in the world. So World Health Ranking and leading cause of death in the Philippines. So first, we have the coronary heart disease or CHD, followed by stroke, influenza, and pneumonia. So the prostate cancer is in the 13th rank. So the risk factor of prostate cancer, which includes age. 50 years old and above are prone to prostate cancer. It is it is because cancer cells mostly develop and occur in older men or person, while race is also a factor in which black men carry a greater risk of prostate cancer than do men of other races. In black men, prostate cancer is also more likely to be aggressive or advanced. So, accordingly to the epidemiology, that black men are twice as risky than any other race. So, family history is also a risk. If your father and brother develop prostate cancer, one man on the same side of the family has had prostate cancer. Obesity. Obese men diagnosed with prostate cancer may be more likely to have an advanced disease that is more difficult to treat. So the signs and symptoms of prostate cancer may be asymptomatic or symptomatic in its early stages. So nodule felt within the substance of the gland or extensive hardening in your posterior lobe. Prostate cancer that is more advanced may cause signs and symptoms such as lesion, stony hard, and fixed. Obstructive symptoms occur late in the disease. So this includes difficulty and frequency of urination, urinary retention, decreased size and force of your urinary stream. So urinary function is most likely to be altered. Blood in urine or semen is also being seen. Painful ejaculation. Cancer be spread to lymph nodes or bone. Symptoms of metastasis includes backache, hip pain, perineal and rectal discomfort, anemia, weight loss, weakness, nausea, oliguria, and spontaneous pathologic fracture, or hematuria may also result from urethral or bladder invasion. And sexual dysfunction is also a symptoms. So, the assessment and diagnostic method is that digital rectal examination, your DRE, preferably used by same examiner. Diagnosis is confirmed by a histologic examination of tissue removed from a surgery from surgery by transurethral resection of the prostate. The third, open prostatectomy, ultrasound is guided transrectal needle biopsy or fine needle aspiration. Another diagnostic is that prostate-specific antigen, the PSA level, transrectal ultrasound, bone scan, skeletal X-ray, your MRI, pelvic CT scans, and monoclonal antibody-based imaging may be also used in diagnosing. So the medical management. So treatment is based on the patient's life expectancy. Symptoms: risk of reoccurrence after definitive treatment, size of tumor, collision score, PSA level, likelihood of complication, and patient's preference. Management can be range from non-surgical method that involves watchful waiting to surgery or such as prostatectomy. So radical prostatectomy. So it is a removal of your prostate, seminal vesicle, tip of the vas, deferens, and often surrounding fat, nerve, and blood vessels through suprapubic approach, which includes a greater blood loss, a perineal approach which is easily contaminated, incontinence, impotence, and rectal injury is more likely to be common, or your retiopubic approach. An infection can readily start. This procedure is used with patients whose tumor is confined to prostate. So, sexual impotence and various degrees of urinary incontinence commonly follow radical prostatectomy. Radiation therapy includes teletherapy and external beam radiation or your EBRT, the treatment option for patients with low risk for prostate cancer. So, brady brachytherapy and internal implants is more commonly used for monotherapy treatment option for early and clinically organ-confined prostate cancer. Its side effect is the inflammation of your rectum, bowel and bladder, proctitis, enteritis, and cystitis, acute urinary dysfunction, pain with urination and ejaculation, rectal urgency, diarrhea, and tenesmus, chronic interstitial cystitis, urethral stricture, erectile dysfunction, and rarely the secondary cancer of the rectum and bladder.
Radiation therapy. Teletherapy or external beam radiation therapy or EBRT treatment option for the patients with low risk prostate cancer. Brachytherapy or internal implants. Commonly used monotherapy treatment option for early or clinically organ confined prostate cancer. Side effects: inflammation of the rectum, bowel and bladder or proctitis, enteritis, and cystitis. Acute urinary dysfunction, pain with urination and ejaculation, rectal urgency, diarrhea, and tenesmus, chronic interstitial cystitis, urethral stricture, erectile dysfunction, and rarely secondary cancers of the rectum and the bladder. Hormone therapy. Androgen deprivation therapy or EDT, accomplished either by the surgical castrations, bilateral orchiectomy or removal of the testes, or by medical castration with the administration of medications such as luteinizing hormone releasing hormone or LHRH agonist. Hypogonadism is responsible for the adverse effects of ADT, which include vasomotor flashing, loss of libido, decreased bone density, resulting in osteoporosis and fractures, anemia, fatigue, increased fat mass, lipid alterations, decreased muscle mass, and gynecomastia or increased breast tissue for male, and mastodynia, breast or nipple tenderness that commonly in men and women. So other therapies include chemotherapy, cryosurgery for those who cannot physically tolerate surgery or for recurrence, repeated TURPs to keep urethra patent, suprapubic or transurethral catheter drainage when repeated TURP is impractical, opioid or non-opioid medications to control pain with metastasis to bone, blood transfusion to maintain adequate hemoglobin levels, and various forms of CEM or complementary and alternative medications. So the patient undergoing prostatectomy assessment is first take a complete history with emphasis on urinary function and the effect of the underlying disorder on patient's lifestyle. So note family history of cancer, heart disease, or kidney disease including hypertension, and note reports of urgency, frequency, nocturia, dysuria, urinary retention, hematuria, or decreased ability to initiate voiding. Preoperative nursing intervention. First is reducing anxiety. Clarify the nature of the surgery and expected postoperative outcomes. Provide privacy and establish a trusting and professional relationship. Encourage the patient to discuss feelings and concerns. 2. Relieving discomfort. While patient is on bed rest, administer analgesic agents. Initiate measures to relieve anxiety. Monitor voiding patterns or watch over bladder distension. Insert indwelling catheter if urinary retention is present or if laboratory test results indicate azotemia. Prepare patient for cystostomy if urinary catheter is not tolerated. By the way, azotemia is a condition that occurs when kidney have been damaged by a disease or an injury. Third is providing instruction. Review with patient the anatomy of the affected structures and their function in relation to the urinary and reproductive systems, using diagrams and other teaching aids if indicated. Explain what will take place while the patient is prepared for diagnostic test and then for the surgery, depending on type of prostatectomy planned. Reinforce information given by the surgeon. Explain procedures expected to occur during the immediate perioperative period and answer questions that the patient or family may have and provide emotional support. Provide information about the postoperative pain management for preparing patient for treatment. Apply graduated compression stockings. Administer enema if ordered. Postoperative nursing intervention. First, maintaining fluid balance. Closely monitor urine output and the amount of fluid used for irrigation and maintain intake and output record. Monitor electrolyte imbalance like hyponatremia, increasing blood pressure, confusion, and respiratory distress. Second, relieving pain. Distinguish cause and location of pain, including bladder spasms. Give analgesics agent for incisional pain and smooth muscle relaxants for bladder spasm. Monitor drainage tubing and irrigate drainage system to correct any obstruction. Secure catheter to leg or abdomen. Monitor dressings and just to ensure they are too snug or too saturated or are improperly placed. Provide stool softener, prone juice, or an enema if prescribed. Monitoring and managing complications. First is hemorrhage. Observe catheter drainage. Note for bright red bleeding with increased viscosity and clots. Closely monitor vital signs and administer medications, IV fluids, and blood component therapy as prescribed. Maintain accurate record of intake and output. Carefully monitor drainage system. Provide explanations and reassurance to patient and family. Infection. Use aseptic technique when dressing changes. Avoid rectal thermometers, tube, and enemas. Provide sets bath and heat lamp to promote healing after sutures are removed. Assist the urinary tract infection or UTI and epididymitis. Administer antibiotics as ordered. Thrombosis. Assist for deep vein thrombosis and pulmonary embolism. Apply compression stockings and assist patient to progress from dangling the day surgery to the ambulating the next morning. Encourage patient to walk but not sit for long period of time. Monitor the patients receiving heparin for excessive bleeding. Obstructive obstructed catheter. Observe lower abdomen for bladder distension. Examine drainage bag, dressings, and surgical incision for bleeding. Monitor vital signs to detect hypotension. Observe patients for restlessness, diaphoresis, pallor and drop in any blood pressure and an increased pulse rate. Provide patient drainage system. Perform gentle irrigation as prescribed to remove clots. For urinary incontinence, encourage patient to take steps to prevent incontinence, improve continence, and anticipate leakage, and cope with lack of complete control. And sexual dysfunction. Erectile dysfunction, decreased libido, and fatigue may be concerned soon or months after surgery. Medications, surgically placed implants, or negative pressure devices may help restore function. Reassurance that the libido usually returns and fatigue diminishes after recuperation may help. Providing privacy, confidentiality, and time to discuss issues of sexuality is important. Referral to a sex therapist be indicated. So, promoting home and community-based care. Teaching patients self-care. Teach patient and family how to manage drainage system, monitor urinary output, perform wound care, and use strategies to prevent complications. Inform patient about the signs and symptoms that should be reported to the physician. Example, blood in the urine, decreased urine output, fever, change in wound drainage, or calf tenderness. Teach perineal exercises to help regain urinary control. As indicated, discuss possible sexual dysfunction, provide a private environment, and refer for counseling. Instruct patient not to perform Valsalva maneuver for 6 to 8 weeks because it increases venous pressure and may produce hematuria. Urge patient to avoid long car trips and strenuous exercise or heavy exercise, which increases tendency to bleed. Also inform patient that spicy foods, alcohol, and coffee can cause bladder discomfort. And lastly, encourage to take more fluids to avoid dehydration and clot formation. In continuing care, refer for home care as indicated and remind patient that return of bladder control may take time. Pathophysiology of prostate cancer. Prostate cancer is a cancer that occurs in the prostate, a small walnut-shaped gland in men that produces the seminal fluid that nourishes and transports sperm. It's most common in men and is the second most common cause of cancer death in American men. African American men are twice as likely than men of any other racial and ethnic group to die of prostate cancer. Predisposing factors include age 50 years old and above, race black men, most common in black men, and family history and obesity. Precipitating factors include lifestyle and occupation. So naa siya tulo ka area which mag-fall siya sa occupational factor, sa age, and the lifestyle. First is ang occupational factor. Example, tricycle driver, testicles exposed to heat, death of testicular cells, necrosis or death cells, necrotic cells absorbed by seminal tubules reach prostate glands. Next is the age. Men aged 51 years old and above. And next is the lifestyle. High intake fat diet and exposure to carcinogens and toxins entered via ingestion and inhalation like pollution and travel to blood and rich prostate glands. And silang tulo is mag-fall sila to or mag-cause sila og infection in the peripheral zone of a prostate. So, normal semen secreting gland cell mutate, development in cancer cells, and formation of small clumps of cancer cells. Clumps din na guys, di na siya clumps, sorry. And during a stage is asymptomatic stage. So, the patient or ang men is di siya maka-manifest og mga signs and symptoms sa prostate. After a nice nag-form naman siya mga small clumps or kanang mga bukol-bukol nga cancer cells. So, mag-spread na siya sa surrounding sa tissues dito sa agianan sa semen tapos mag-form na din siya og tumor. So, gamay man kay ang gianan sa semen, so na siya compression of urethra. So, mag something huot na kayo ang gianan sa kanang so na may compression of urethra gakahitabo pasabot kung strict na or gamay na king agianan sa ihi or sa semen, so mag-create na siya weak urine stream or mag-down pa siya to inability to urinate, hematuria na siya kanang dugo siyang ihi tungod sa pressure masamad na siya, so na siya mag-create na siya lesions, so dysuria, hematospermia. Siyempre siya sa ihi kailangan mo siya pressure gyapon, so mauban na ang dugo sa sperm sa pagawas, so polyuria and mudaon pa siya sa nocturia, and then mag-fall na pudan silang tanan o mag-metastasize, then mag-invade din ang seminal vesicles and ma-infect na din ang testicles. So diri nga time is maka-feel na gyud ang men og signs of symptoms na dayon nga deep pain in lower abdomen, back and pelvic nga grabe na gyud kasakit. Then magkuan na siya, create na din siya prostate cancer. So kasagara gyud siya sa early stage is no symptoms, no signs and symptoms gyud ang patient. So may bal-an na siya sa patient or sa men nga na siya signs of symptoms dito nga sa mga late stage na siya nga mo paingon na siya sa pagka-cancer. So, medical management include transurethral resection of the prostate or TURP, prostate specific antigen PSA level, transrectal ultrasound, bone scans, skeletal x-rays, and MRI pelvic CT scans, or monoclonal antibody-based imaging, and teletherapy, and brachytherapy, androgen deprivation therapy or EDT. And narang signs of symptoms dili na siya maibalaan if paingon na siya sa pagka-late or sa cancer na yun siya paingon. Lesions, difficulty in urination, urinary retention, blood in urine or semen, painful ejaculation, anemia, hip pain, weight loss, weakness, nausea, oliguria, and sexual dysfunction. And the nursing management include reduce anxiety, relieve discomfort, provide instructions regarding suture care and functions of urinary and reproductive system, maintain fluid balance during postoperative care, relieve patients' pain, monitor and manage complications include hemorrhage, infection, thrombosis, and obstructive catheter, urinary incontinence, and sexual dysfunction. Thank you and have a good day.